We are live now, doctor.
Okay.
Yeah.
So, good evening, respected seniors, colleagues, and all the wonderful and dynamic residents who have logged in today evening. I am Dr. Vishal Agarwal. I am the Scientific Committee Chairman of Rajasthan Ophthalmological Society. And it gives me immense pleasure to welcome you all for yet another masterclass of the online PG teaching program Kaksha. Kaksha is a novel PG teaching program by ROS which will cover all the major topics over a period of next 2 years of the current PG curriculum in India. We'll be bringing the best of national and state faculty experts to share the knowledge and interact with you. The residents who have joined in, the fellows who have joined in are also encouraged to put forward their doubts in a fearless manner and ask their questions by raising their hands or typing in the chat box. Coming to this class, we have today with us Dr. Raja Narayanan from LV Prasad Eye Institute, Hyderabad, to teach us and enlighten us about a very commonly seen entity in the OPD, that is diabetic macular edema. It is a very important topic, not just for the PGs and fellows, but also for all practicing ophthalmologists, anterior segment surgeons also, and frequently asked in theory as well as practical exit exams. And Dr. Raja is an authority for the same. We also have with us two seat residents today, Dr. Soju and Dr. Surbhi. Soju and Surbhi, are you here?
Yes, sir.
Okay, so they are all final year residents from different colleges in Rajasthan, and we request her to ask them questions informally, and they can also raise their doubts. And the questions are open to everybody in the audience. I'll be introducing Dr. Raja sir by reading out a few highlights from his enormous and illustrious CV. Sir did his MBBS from Maulana Azad Medical College and his post-graduation from Guru Nanak Eye Center, MAMC Delhi University, and his MBA from Symbiosis University. He's presently the director of Anand Bajaj Retina Institute, LV Prasad. He's the director of Human Resources also there. He's the director of Suven Clinical Research Center at LV Prasad. And at present, he's also the adjunct professor, University of Rochester School of Medicine and Dentistry, New York, USA. He was the past general secretary of the Vitro Society of India, and he's the co-founder of I Hope Center for Clinical Research. If all the people who do not know what I Hope is, it is a charter to create a center for new knowledge and research in clinical and public health and health economics field, which will guide the health policy in India and the developing world in ophthalmology and beyond ophthalmology. And it is funded by Government of India and the Wellcome Trust UK. He's the editor-in-chief of the I Hope Journal of Ophthalmology. Dr. Raja has more than 20 years of experience in the field of retina, has performed more than 8,000 major vitrectomies, including endoscopic vitrectomy, subretinal surgeries, choroid RP transplant, and 3D heads-up surgery. Almost 80 fellows have been trained under him, and he is of H index 35 and I-10 index 94 in peer-reviewed publications. He is on the board of editor of journals like International Journal of Retina and Vitreous, Seminars of Ophthalmology, and IGO. I now welcome ROS President Dr. Sanjeev Desai sir, President-elect Sir Dr. Virendra Agarwal, and our dynamic secretary from Jodhpur, Dr. Ghulam Ali. I request Dr. Raja sir now. I just forgot, there are two grand prize questions at the end of the presentation. So listen carefully and hold your vigil, because these questions at the end of the presentation will carry attractive prizes and will be delivered, whoever is the winner, to your workplace or residence. I now request Dr. Raja sir to share his presentation and start his class. Sir.
Yeah, thank you, Dr. Vishal, Dr. Ghulam Ali, ROS. Thanks for the very lengthy introduction, which probably was not required. But it is my pleasure to interact with the residents. It is always a pleasure to talk to the residents and see how we can impart our knowledge so far, our experience, so that they learn from our thoughts and sometimes from our mistakes as well, and so that you don't commit those mistakes which we have committed earlier. So it's a platform for sharing our thoughts overall. I would just request the residents to take down some important points. Nowadays, a lot of people are into digital. You just keep saving and accumulating a lot of slides, PowerPoints, PDF, document. But I would say that writing down yourself or making a drawing or a figure or a table yourself is more than half learning, because the PDFs and PPTs which you save, we don't know when we will open them. So in each of these slides, there may be some important points, but if you feel there is something important that you are seeing in one slide, just make a note of it. So this figure which is there in this slide is a very important figure related to diabetic retinopathy, related to our class, management of diabetic macular edema. So in India, there actually are more than 70 million diabetics or patients with diabetes. More than 70 million, that is 7 crores. So there are so many patients with diabetes that we lead the world in terms of number of patients with diabetes. And that's all you need to remember from this slide. Before we start talking about treatment of diabetic macular edema, one must be very thorough and an expert in knowing all the layers of the macula, all the layers of macula as seen on OCT, because OCT is a very, very important tool for any retina specialist, or not necessarily a specialist, but even if someone is a comprehensive ophthalmologist who wants to treat some retinal diseases or make a diagnosis, they should know each and every layer of the retina. Only then a proper diagnosis can be arrived in many, many instances, and you may avoid pitfalls of making a wrong diagnosis. So I just wanted to ask Dr. Soju, and who's the other person who will be interacting today? Sorry.
Surbhi, sir.
Okay. So Dr. Soju or Dr. Surbhi, would you like to take a shot at this slide of OCT and describe it?
Sir, there is collection of fluid. There is subretinal fluid with multiple stored spaces within the retinal layer, and also disorganization of retinal layers are present, sir. So,
Okay. Dr. Surbhi, would you like to add anything or say something? I'm not sure if she's there, but very nice attempt, Dr. Surbhi. Very nice. I'm not sure if you have ever described fundus photograph, and when we describe fundus photograph, there is a set pattern with which you start. You always say so and so eye, and the media is clear. Before we start saying there is envy there or a cotton wool spot there is a way to describe. Same way for the OCT, at least in this scan, quite a few scans you as a resident may not be able to make out right eye or left eye, but this scan is very nicely, you can make out which eye scan this. This is the optic now. If you can see my cursor moving, this is the optic now, this is the fovea. So this is the left eye scan. And when you start describing an OCT, you start from the vitreous, you start from the top. And you can tell if the vitreoretinal interface is normal or not. How is the foveal contour? Then you describe the intraretinal details layer by layer. Then you go to the subretinal space if there is anything. Then you describe the RP and the choroid. So there is a systematic pattern in which you describe the OCT. In this eye, the vitreous is clear. Sometimes you can see dot-like reflectivity in the vitreous, which may either signify vitreous cells, as in uveitis, or if you see some very mild vitreous hemorrhage, that can also be picked up in diabetic retinopathy patients in the vitreous on OCT scan. But here, what we are interested in is, as Dr. Soju pointed out, there is some intraretinal fluid. But again, it's very important to qualify in the management of diabetic macular edema. The most important thing is whether it is center involving or not center involving. That makes a huge impact on how you are going to treat your patient. In general, center involving macular edema, we straight away go for injections. In non-center involving macular edema, in general, we either observe or do laser. We'll come to more details later on. There may be exceptions, there may be other evidence, there may be some protocols. But the general point I made, you can please make a note. Center involving macular edema, generally we go for injections. Non-center involving macular edema, we generally either observe or do laser. Okay, and this eye also has subretinal fluid. Okay, so let's move on to the next slide. So, Dr. Surbi, are you there? I'm not sure if you have logged in or earlier is you could not describe. Would you like to describe, let us say, the left eye fundus photograph? Is she there, Dr. Surbi, or Dr. Soju? Would you like to describe the left eye photograph in this?
Yes, sir. So there is multiple hard exudates present in and around macula with multiple hemorrhagic lesions present inferiorly as well as central retina. I think some microaneurysms are also present.
And what is there in the lower part of the fundus photograph?
The intraretinal hemorrhages are present, sir.
And this large red patch?
Maybe subhyaloid hemorrhage.
Okay. Now, do you think that hemorrhage is in front of the retina or is it behind the retina, the large patch on the inferior part of the fundus photograph?
It may be periretinal subhyaloid.
I just wanted to know if you think it's behind the retina or in front of the retina, right? So, if it is in front of the retina, it will obscure the blood vessels. If it is behind the retina in the subretinal space, the retinal blood vessels will still be clearly visible. So it is in front of the retina, okay? But again, as I was mentioning, while you have described quite a few features, that's very good. But there is a way to go about describing fundus photograph. You start with the eye, which we already said, the left eye. Then you start with the media. You start with the media clarity. You start with the vitreous clarity, and then you talk about the disc size, the cup disc ratio, the neuroretinal rim. Then you describe the blood vessels, the arteries, the veins, the AV ratio. Then you come to the macular features and then to the peripheral features. That way, your examiner also knows that you know how to systematically evaluate a retina, and also this helps in making sure that you are not missing any finding. Because sometimes we are so focused, as soon as we see something which you think you know, let's say you are able to find a retinal detachment in a photograph, but you miss that there is a lot of vitreous haze and there is some blood vessel changes of vasculitis, and you directly jump to a retinal detachment and start talking about Linkoff's rule, when actually the vitreous haze of vitritis and vasculitis actually is pointing towards an exudative retinal detachment. This is just as an example. So you must go systematically when you are describing any photograph. Now, the previous photograph which I showed is a wide field photograph. It's of Clarus Zeiss. And nowadays we have ultra wide field photograph, which is by Optos, where we get more than 180-degree or close to 200 degrees of imaging. So in this and the other left eye, while it gives a lot of wide field, extreme wide, ultra wide field, but you will realize that compared to a regular wide field photograph or even a macular photograph, in this you can see the hemorrhages very nicely, you can see the exudates very nicely, whereas in ultra wide field photography, although it's ultra wide field, not all the hemorrhages or not all the lesions are easily recognizable, because ultra wide field is based on SLO imaging, whereas wide field Clarus imaging is a true color imaging. So Optos or ultra wide field gives the advantage of periphery, but you may lose out on some of the clarity or resolution of the images. This, anybody wants to tell what is this image?
Anybody can answer from the audience. You just switch on the mic, or you can type in the chat box also.
What image is this showing? What imaging modality is this? Is this a color fundus photograph? Is this an autofluorescence? What exactly? Okay, so this is an angiography. As you can see, all the blood vessels are nicely visible, but the only catch here is that this is a dye-less angiography. There is no fluorescent dye in this angiography. It is a wide field OCT angiography. Nowadays, you might have heard about OCT angiography, where you can see the blood vessels in a segmented manner. Segmented manner means you can look at it layer by layer. You can look at the inner layer of vasculature separately of the retina. You can look at the deeper layer of vasculature of the retina. You can look at the choriocapillaris layer. You can look at the choroid separately. Whereas in a fluorescein angiography, you cannot separate the layers out. Whereas in OCT angiography, it is depth resolved or segmented angiography. And this one is a wide field OCT angiography, and the arrows are pointing at the neovascularization, NVE, which you can see as nice vascular loops. And when we do a regular angiography, now this one is of the same patient, same eye, And this is dye angiography, that is fluorescein angiography. And this also shows those leaking spots of NVE, and you see the peripheral non-perfusion in this. But the same can be picked up, these capillary dropouts, non-perfusion can be picked up on dye-less angiography also. And this is the late phase of the actual fluorescein angiography, showing the multiple NVs, which even the wide field OCT angiography also picked up. This is the comparison of OCT angiography on the left side and fluorescein angiography is on the right side of the same patient, same eye. And you can see the NVEs which were there in Octa on the left-hand side photograph. They are all leaking on the right-hand side. In Octa, since there is no dye, you won't see any leakage, but you can see the neovascularization very nicely even on Octa. This is the same patient left eye. You can see some neovascularization where the arrows are pointing out, and also some dark areas of capillary non-perfusion. And this is the fluorescein angiography of the same patient showing all the dye leakage. Now, this is the neovascularization of the disc. And in diabetic retinopathy, it's important to realize that it's not just the macula or the posterior pole where you may have your findings. The findings may actually sometimes be more predominant in the periphery also. In about 30% of cases, they may have predominant peripheral lesions. So just by looking at the posterior pole, if you think that there are no lesions, don't get distracted by that. The patient may still have either NVE or a lot of hemorrhages in the peripheral area. So you must examine these patients beyond the arcade as well. And staying on with OCT angiography, which I said is depth resolved, you can also look at the FAZ or the ischemia in these patients, both superficial capillary plexus as well as the deep capillary plexus. And you can look at the ischemia as in the top photograph OCTA, the deeper plexus, you can see the FAZ is distorted significantly, and there is a lot of ischemia extending beyond the FAZ, which means it is enlarged. That means these patients have slightly poorer prognosis. Now, with that, I have just initiated the first part of the management of diabetic macular edema with the investigations. Now we will come to the treatment. But in all of this, it goes without saying, you can never overemphasize that systemic control is extremely important. But systemic control is not something that you leave it to the physician and just let them do whatever they want. You must be aware of your patient's HbA1c. While the control may be done by the physician, but you must ask and you must record every patient's HbA1c, their lipid profile, their blood pressure, and the anemia, and the renal parameters. You must make a note of these in your patients at least at baseline, because these make a huge impact on the overall outcome of the patients. Now, in terms of the treatment of the diabetic macular edema, there have been various protocols, numerous protocols of DRCR itself. Now, these are some of the important protocols which I have listed here of Diabetic Retinopathy Clinical Research Network of US, DRCR. It's not to show that you must memorize them. There's no point, memorizing just for the sake of an exam. But all I would like to point out is these guide us for the management of patients. When I say guide us, it tells when to use which injection or whether these injections are comparable, And also it tells us what is going to be the likely outcome in our patients. Meaning, if you have a patient in your OPD, in your clinic, what should you tell your patient based on these different protocols which have been there, which injection to use, when to switch, and what can you tell the patient in terms of their outcomes? Because patients will ask, doctor, will I get back my vision? And you may say, I will give you 3 injections and see, or I will give 6 injections and see. But you still need to give some guidance. Seeing means, what do you mean by that? Will I get 6 by 6? Or will I become worse than what I am today? What are you trying to achieve with your injections? And there are very, very clear-cut answers to them. Very clear answers have been given by these protocols. As long as the patient follows that protocol, you are very likely to get that particular outcome of that protocol. But I will share some of the important protocols. Most important have been protocol I, T, and V. I'll just briefly mention these overall results, but also I'll show you how to not memorize, but it will automatically be embedded in your brain when you talk to your patients. So this, one of the earlier protocols, protocol I, was comparing ranibizumab with laser and intravitreal triamcinolone. Now IVTA, intravitreal triamcinolone, is not commonly used now. It used to be commonly used earlier, but in this figure or graph, it has not been shown because it's not that much used and the results were not that great, at least in phakic patients. But what you can see is that the patients gained 9.8 letters. 9.8 letters if you gave them ranibizumab injections for 1 year or at the end of 2 years. Now, I will come back to this. What does this 9.8 letters mean? Okay, but this you will now at least remember that with ranibizumab, you round it off. Let's say 10 letters is the gain that you are going to get at 5 years follow-up in your patients. What about protocol T? Protocol T compared aflibercept, bevacizumab, and ranibizumab. Can anyone tell what is aflibercept, what is bevacizumab, and what is ranibizumab? Anybody? What is aflibercept?
Come on, guys, this is a very simple question. So they're typing in the chat box. You can see those responses.
Okay, I'm sorry, I didn't look at the chat box earlier. Very nice. You guys are giving the. Okay, so anybody, what is aflibercept, the brand name or the trade name? What is bevacizumab? What is it? Eyelia. Dr. Manisha Singh is the first to answer. Eyelia, excellent answer. Wonderful. So bevacizumab is Avastin. Ranibizumab, originally you had Lucentis or Eccentrix. Now there are other biosimilars. Dr. Pawan has very nicely mentioned. Bevacizumab is Avastin. Now, these are the commonly used anti-VEGFs. So we need to know what happens with which anti-VEGF, right? It's a daily question. It's a common question for any retina specialist. You have a patient with diabetic macular edema, you have 3, 4, or 5 injections now available, and you don't know what to tell the patient. The patient is confused. Now you are getting more and more different injections now. But you can learn from these trial data, okay, what happens in which patient. Now, this is a very important slide. It compares the results of bevacizumab. Bevacizumab is the red line. I'm sorry, the legend is not there. The red line is bevacizumab or Avastin. The light blue line is ranibizumab or Lucentis. This is US-based trial. So Lucentis, but 0.3 milligram. We in India use 0.5 milligram. And this dark blue line is Eylea or aflibercept, 2 milligram. Now we don't have high dose as of now, but this is Eylea, Lucentis, Avastin. Now, protocol T clearly showed that in patients who have visual acuity less than 20/50, Eylea gives a much better response than Avastin or even with Lucentis. But there is a huge gap of more than 5 letters between Eylea and Avastin. So if a patient has vision 612 or less, the 20/50 is somewhere about 6/15. So the other challenge which all of us have as residents is the American, all the journals say 20/40, 20/60, 20/80. But I, in my clinic, in my medical college, it says 6/12, 6/9. I just can't make out what is what. That's the first level of confusion right there itself. But I will show how easy it is to remember. But from this slide, what you can make out is that any patient whose vision is less than 6/12, that is worse than 6/12, Eylea gives definitely a better response compared to Avastin. But if it's better than 6/12, all three of them are similar. So if you have a patient with 6/9 vision, center involving macular edema, and you have these choices, you can see that all three of them tend to behave the same. Now, what would you choose? Probably something which is the most inexpensive or cheapest option. So something somewhere, a drug which doesn't have much of a difference in efficacy, probably patient is going to choose the cheaper option. But if there is a difference in the efficacy, the patient may opt for a more expensive option. Now, this is a capsule. I just want you to make notes out of this capsule. It's simple mathematics. Now, in British style, it is 6/6, 6/9, 6/12, 6/18. I'm not going to ask what does the numerator mean and what does the denominator mean. We should all know about it. But the American style is 20/20, that is 20 feet. 6 meters is 20 feet. So the way they write is 20/20, 6/6. Okay. Now what is 20/40? You just keep your numerator the same. 20 in our style, you have to make it 6, okay? But the denominator, you can easily convert. 20/40 is 1/2. So 6/12 will be 1/2. So 20/40 is the same as 6/12. So if somewhere in an article you read 20/60, what does it mean in terms of 6 by what? 20/60 is the same as 6/18. That is 1/3, 1/3. If you have someone's vision noted down as 20/200, what is it in 6/60? 20/200 is 1/10. 6/60 is 1/10. Very simple. 20 divided by whatever, converted into 6 by the same fraction or the same factor. Okay. I hope you have all understood this, because you will find it much easier to understand articles. There is another way or two ways people write nowadays in various articles. One is decimal. Decimal is very easy. 20/20 is 1. 20/30 or 6/9 is 0.66. It's just a fraction. Okay. But there is another way called logmar. Generally, logmar you'll have to refer to a table. They are easily available. But if you are doing a lot of studies or reading a lot of articles, you will start, kind of memorizing them as well. But 20 by X vision is equal to 6 by Y vision. You know now how easy it is to calculate. But again, going back to these articles, when I mentioned that 18 point so and so letters is gained in protocol T, if you give Eylea at the end of 2 years, versus let's say with Avastin is about 12 letters. So it's a difference of 6 letters between Eylea and Avastin. 5 letters is 1 line. Okay, so 20 by 20, 20 by 25, then 20 by 30. Now these visual acuity charts have slightly more lines compared to our regular, that box Nellen which you have in hanging on the wall. These 20 by 20 charts have slightly more lines, but each letter has an increment, or each line has a gain of 5 letters. Okay, so 5-letter gain is 1 line gain. 15-letter gain is 3 lines gain. So if protocol T says that Eylea patients had an improvement of 18.3 letters, it was between 3 and 4 lines of gain. So you can imagine 3 to 4 lines gain, 2060 to 2040 to 2030. That's actually a 3-line gain. Yeah, so 3 lines is simply half or double. So if 40 to 20 is 3 lines, 60 to 30 is 3 lines, 200 to 100 is 3 lines. That's a very simple way of calculation. So 15 letters or 3 lines is a very important number. It's a magic number for all clinical trials. And this is another statistical capsule which we have here. Just give me just give me 1 minute.
Sure, sir.
Yeah, thank you for your patience. My parents had come, my uncle had come from US, so I went to say bye to them. Yeah, so we will continue now to this beyond the um, capsule now. So the OCT outcomes in terms of the macular edema thickness, if you look at the overall thickness reduction, no, this is not the thickness, but the thickness reduction. More drying effect means it will be lower down. Less drying effect means will be higher. So bevacizumab or Avastin, and if you compare that with ranibizumab and aflibercept, so bevacizumab has the least drying effect. That means if there is a lot of edema, bevacizumab is not a good option in general because it has less drying effect. Ranibizumab is somewhere in between, and aflibercept has the maximum drying effect among these three. Okay, so if you want really good drying effect, aflibercept has the maximum drying effect. Okay, but we also discussed about the visual acuity changes in general. So I will present some cases now. This is a 51-year-old male who came to me long ago, more than 10 years ago. When he came to me, he already had a history of um, diabetes for 10 years. His HbA1c was 7.8, which is not good, but it's somewhere in the middle, but definitely not good control. He also was hypertensive, which was controlled, and he also had dyslipidemia. He was on statins for that. Visual acuity in the right eye was 20/80, and in the left eye was 20/20. Now, can anyone tell what is 20/80 in terms of 6 by? What does it mean? 20/80 is equal to 6 by what? Let us see if I am getting posts on the chat box. Very nice. Dr. Siddhi Mathur, Dr. Manisha Singh, Dr. Nikita Gupta are paying very good attention. They have answered correctly. 6/24. Dr. Deepa as well. So excellent answer. 6/24 in the right eye. And the patient has hard exudates involving the center, and the left eye has microaneurysms and hard exudates, but the hard exudates are not involving the center. And I can also share with you that the right eye, the foveal reflex is lost, and the choroidal reflex is not very clear in the right eye macula, whereas in the left eye you see very sharp all the features, including the perifoveal blood vessels, and also the choroid through the retina is nicely visible. So if we do OCT in this patient, what do you expect to see in the right eye and what do you expect to see in the left eye? Hint is that this patient's vision in the left eye is 6/6, in the right eye it is 6/24. So if we do an OCT, what do you expect in the right eye? What do you expect in the left eye? We will wait for a few seconds. You can post your answers in the chat box. So in which eye do you expect? Excellent answer. Dr. Deepa has already written macular edema in the right eye. Dr. Soju has written CSME. She means macular edema. Now, CSME is more of a clinical finding and older terminology, but on OCT we mention macular edema or fluid and center involving, right? The right eye it is involving the center, right? Now, what you both have done today, Dr. Deepa, Ajit Kumar, as well as Dr. Soju, you have done a very important thing, actually not just today, but in your career. What we need to do is whenever we order an investigation, we should have an appreciation of what to expect, because clinical judgment, clinical examination is the most important, today's test for us actually. But we hardly use the stethoscope, we hardly use any equipment in terms of our clinical skills. We all just rely on scan A or scan B or this blood test or this MRI or CT scan, and then look for what it says. Whereas as a doctor, you must make a differential diagnosis or a judgment based on your clinical examination, and then order a test more or less to confirm what your clinical judgment is, not the other way around. It should not happen that you don't examine a patient, just order an OCT and then let what the OCT has to guide you. OCT should not be your master. You should be the master of OCT. Okay, so let's see what happens here. We'll skip the fluorescein angiography here. As has already been predicted, it was a good prediction by Dr. Deepa Ajit Kumar and Dr. Sodhu. They said that there will be macular edema, center involving macular edema, 846 microns. That's massive edema. That's massive edema. Okay. And I don't think I am showing the left eye scan. I think I had deleted it. The left eye was normal. In the sense the left eye OCT did not have any macular edema. Okay. Now, based on so far our learning today, protocol I, we carefully looked at protocol I, right? All of you residents. With this edema, what would be your drug of choice for injection? Please post in the chat box. Is it going to be bevacizumab? Is it going to be ranibizumab? Or is it going to be aflibercept? Okay, which one has the maximum drying effect? You all learned. Which one has the least drying effect? You all learned. Now, based on this, you should be able to make a judgment what all you want. And we are getting very nice answers in terms of variability. Some have posted ranibizumab, some have posted Eylea or aflibercept. Dr. Rohit Kapoor has gone ahead and mentioned Eylea plus tricot. Now, at least we are having you people think here. So, shows which is a whenever less than 612 or so, this patient has 6 and 800 microns is massive. Now, in terms of between these three drugs, aflibercept is the best choice. Now, whether the people would
Dr. Raja, are you there? Manjula, just check whether he got disconnected.
Check, doctor.
We can reconnect actually. Just wait for 1 minute. We'll try to connect Dr. Raja again.
Hello.
Hello, sir. Good evening.
हाय विशाल, क्या हो गया भाई?
सर उनका डिस्कनेक्ट हो गया, दोबारा कनेक्ट कर रहे हैं अभी अभी।
यही।
जी सर, श्योर, नो प्रॉब्लम, वी वेटिंग। ओके, नो प्रॉब्लम, टेक योर टाइम। कनेक्शन
Okay.
कहते हैं इज जॉइनिंग इन 1 मिनट।
Okay.
Starting with all the basics, मतलब very comprehensive, how to read and how to interpret the visual acuity.
A very nice presentation actually.
Very nice.
राजकुमार बस, गुड इवनिंग।
सर गुड इवनिंग, कैसे हैं?
बस बढ़िया, फर्स्ट क्लास। आप कैसे हैं?
मजा, आनंद। कैसे हैं विशाल जी?
तो आशीर्वाद है आपका।
क्या बात है, बुजुर्ग बनाए जाओ हमको। हम्म।
Yeah, I'm extremely sorry about that. I hope.
No problem, sir. We are still here.
Yeah.
Raja sir, you are connected. Can you hear me? So can you hear me now?
Yeah, I can hear you. And sorry about that. I had to change the laptop completely.
Yeah, no problem. You have the presentation on this laptop?
Yeah, I just now shared it because it kind of crashed in the sense there's no. Yeah, so just let me open my presentation. Just a second.
The presentation is visible, sir.
Yeah, is my presentation visible now?
So it was visible just before you clicked that button. Now it is not. Can you just
Okay.
toggle the PowerPoint? I think that will make it visible. Yes, now it is visible, sir.
So what I will do is, yeah, now it should be visible.
Yes, it is visible, sir.
Yeah, so yeah, so yeah, I'll just then speed up some part of the presentation. Then I'll go to a different case. The first case, what happened was after 4 injections of bevacizumab, this patient was treated more than 10 years ago. At that time, ILIA was not launched at that point of time. So this patient had received bevacizumab, but unfortunately, this patient um lost to follow up after 3 injections. So then he came back with massive edema, even in the left eye, and then with bevacizumab, it didn't work much. But then the question comes is when would you switch? Now, in general, there are some guidelines of when you may want to switch, but different countries have different guidelines. We'll see with respect to one of our patients. This patient, you had described the color fundus photograph earlier. This patient has vitreous hemorrhage in the left eye with multiple NVs. The right eye has a few NVs. And right eye also has a lot of center involving macular edema, vision of 20/50 N8. The left eye had less macular edema, 20, 30 and 6, but still center involving. So this patient underwent PRP along with bevacizumab, and the edema reduced in the right eye. Vision also improved to 2040 and 2050, and left eye also edema reduced. We repeated the bevacizumab because edema is still persisting in both right eye as well as left eye. But then again, after 2 months of follow-up, the edema came back. There was a rebound. Right eye 2050, left eye also the edema came back. So this patient, after 2 injections, we decided to switch to aflibercept, and with that, the edema substantially reduced in the right eye. Left eye it almost went away. We repeated the aflibercept. There is still some edema, but what it showed is that you probably should be ready to switch to aflibercept even if you are starting with bevacizumab or ranibizumab. The best drying effect is with aflibercept. So if you have a patient who, for let's say cost considerations, you are trying to use some other agent, but after 2 or maximum 3 injections, we tend to switch in our country, whereas the other country guidelines, such as US guidelines, they generally go for 6 injections and then only switch. So this was done by the Vitreoretinal Society of India, a survey after how many injections would you switch. Some doctors would switch by 2 injections, but most doctors would switch. Almost 70% would switch by the third injection if there is no response. And if there is a need to switch, many of the doctors actually switch to steroids uh, rather than switching anti-VEGF agents. But in general, what we would prefer is if there is a lot of edema, you should go for aflibercept. If there is mild edema and good vision at baseline, you can use ranibizumab or bevacizumab. In terms of patients who have very good vision at baseline, let's say 6 by 6 or 6 by 9, these patients, there was a trial called Protocol V, where they looked at patients with very good vision, mild edema. They looked at either aflibercept or laser or observation, that is doing nothing, just observe them, keep them on good control of systemic parameters, and look at the outcome. What they found was that with all three of them, either aflibercept or laser or observation, there was no difference in the outcome. So, in overall, patients who have very good vision at baseline and the edema is not much, you can even choose to observe them, and you can start injecting them if the vision becomes poorer, that is less than 6 by 9. That's also an option.
क्योंकि
So
hello
another case here, 49-year-old female, sugar is very high, 235. Patient had uh, diabetic retinopathy with was advised injections elsewhere, and you can see that left eye patient also has some subhilar actually of the disc. So this is actually a patient of PDR,
हाई
proliferative
एक्सपेक्टेशंस होती है
diabetic
ना जब तब दिक्कत
retinopathy.
होती है
And so, what would you expect on OCT in this patient in the left eye at least? Can anyone guess? Yeah, so this patient has fibrovascular proliferation over the disc, and you can see that there are some folds going on to the macula. So you'll be seeing epiretinal membrane and vitreomacular traction in the left eye. The right eye, you can see the foveal contour is maintained. And I was mentioning in the initial OCT slide, what all to look for. You see the vitreous. You see the vitreous has a lot of stars, starry sky in the vitreous. In a patient of PDR means there is definitely a mild subhyaloid hemorrhage. You can see that the hyaloid is lifted a little bit. You can see that NVD is there, hyaloid is lifted, and so many dots in the vitreous. This patient is subhyaloid hemorrhage. but not much of edema. In the left eye, the photograph which I had shown and asked, there is a significant fibrovascular proliferation, and you see the intraretinal schisis in this. So this patient is definitely a case in the left eye. Because of so much of traction, you must go in for vitrectomy in these cases. Now, in this patient, the left eye patient did very well, but I'm going to show a representative video of another patient, not this patient which I was discussing earlier. This is a very bad traction retinal detachment with sclerosed vessels. I'll be just showing the video here. First, you do a vitrectomy. Uh, you must remove all the hyaloid around the membranes before you start attempting to do a segmentation of these fibrovascular membranes. And Jaipur, Dr. Vishal Agarwal, he's an artist of presentation. We must show very bad tractional detachment. The disc was not visible, the macula was not visible. You have so much of fibrous proliferation and traction. With the cutter itself, sometimes you can complete the entire surgery, sometimes you may have to do bimanual surgery. That is, in one hand you use forceps or scissors, and in the other hand you use the forceps. So with that, you can slowly remove all the membranes. You have to be very gentle because otherwise you can create retinal breaks. And once you complete the removal of all the membranes, the final stage you can use the cutter to just remove all of them. And at the end you do this is a different color channel that I'm using, but the entire membrane more or less have been removed, and then you can do the fluid air exchange and laser in these patient at the end of the surgery. You can see the endo laser being done at the end. So in this patient, you can see the top left is before the surgery, and in the bottom right you can see the traction has been relieved. You can see the disc, you can see the macula and arcades. So these are tough surgeries, but these sometimes have to be resorted to. In terms of the latest therapies that we have now, brolucizumab as well as faricimab. So original molecule of anti-VEGF was pegaptinib, then we had ranibizumab and bevacizumab at the same time, then we got aflibercept, then brolucizumab in 2019, and now recently we have faricimab, which is a bispecific antibody going to be launched soon in India. It acts against both angiopoietin 2 as well as VEGF-A. So it's more durable, meaning it lasts. You can have the patients on even 4 monthly injections instead of the earlier anti-VEGF, which you had to give once in 4 to 6 weeks or 8 weeks. So the results comparing faricimab and aflibercept showed that both have similar gain in vision, 10.8 letters at the end of 2 years, which is about 2 lines. So these patients, only thing advantage with faricimab is you can extend them even up to 16 weeks, many of these patients, and that helps in reducing the number of injections. So in conclusion, in DME, we generally start with anti-VEGF, we switch in 2 to 3 injections in the Indian protocol. If there is no significant improvement, we don't wait for 6 injections before we switch. Steroids can be used for maintenance therapy, but as I had shown in the video, vitreomacular traction or ERM, you may have to resort to surgery. Although with mild ERM, you may still try injections, but you must be prepared for surgery. And the other thing I want to say is get trained even in giving injections. While it may appear that you see the OCT, there is any edema, you want to give the injection, but you must get trained. get trained in both OCT or management or evaluation, and then getting trained in the treatment part also. So this was a patient who was who came to me for another opinion by himself. He was told that he has some swelling in the retina. Yes, but the patient had. Now I examined the patient with 90D very can myself. The foveal reflex
Sir,
was dull,
can you
but
repeat
I could
the
not
last sentence
find out the
because
reason or cause of the macular edema. It's very important to know the cause of the macular edema and not just treat the OCT.
sir, can
So
you
when I repeated the OCT, what we found was that this patient has a macular hole. So the macular hole edges have macular edema. They have cystoid changes at the edges. So when you look at the scan, make sure that you look at all the scans of the patient and not just one printout, because one printout or one scan, it's like if you have a big film of CT scan or MRI and only one section being given to you. What kind of interpretation can you make? You have such a huge brain in terms of the CT scan sections going through different parts, but if someone gives you a film with only one scan and one section, you just won't be able to make any decision. Same way with OCT, make sure that you look at all the scans so that you make the correct diagnosis. So instead of treating this patient with injections, actually you have to do a vitrectomy in this patient. The other aspect of training which I would like to emphasize, apart from the diagnosis, is the injection itself. Don't try to give injection if you have not been trained in those injections. This is a cataract surgeon who is giving intravitreal injection of Ozurdex or dexamethasone implant. Now, cataract surgeon or as a resident or as a beginner, you are afraid or scared of retina, so you always tend to be parallel to the pupil. Whereas in intravitreal injection, you have to give within the vitreous. So, cataract surgeon, when they give intravitreal injection, you may end up giving inside the lens. And this surgeon who ultimately did the cataract surgery had to remove the Ozurdex implant because by accident they had given the injection within the lens. So with that, I would like to thank you for your attention and also staying on in spite of the internet issues. And sorry for the trouble. And I have a couple of questions for quiz. So
sir, can
Dr.
you hear me?
Vishal, if you want. Yeah, I can hear you, Dr. Vishal.
Sir, you just present the question. We'll give them 10 seconds is enough to
Yeah,
answer.
sure.
So you can speak the question and then whoever types in the chat box first will get the grand prize.
Sure. So this OCT shows there are four options: intraretinal fluid, 1, 2 is subretinal fluid, 3 is both intraretinal and subretinal fluid, and 4 is intraretinal fluid with PED. So which is the correct option in this?
Sir, all have typed the third option. Manisha, Akshika, Siddhi, Suju, Nish, and
So
Chiruta has
who had the
typed.
fastest finger first?
Fastest finger is Manisha Singh. Intraretinal plus subretinal.
Who had the fastest finger?
Sir, Manisha.
Sorry, I'm not able to hear you.
Manisha, where are you from? Sir, I have noted the answer. Can you proceed to the next question?
Yeah. So this is the next question. A 54-year-old patient with diabetic retinopathy (DME) has visual acuity of 20/60, and based on protocol T, aflibercept was injected. So what is the expected visual acuity at the end of 1 year? Remember the class I have taken today. What is the number of letters that they have gained in Come to today 20 by 60. What is the expected vision? Do you think it will be the same 20 by 60? Will it be worse, improved to 20 by 30? Or will the patient be really bad with hand motions? So these are the four options: 20/60,
So the
21/20,
baseline vision was
20/30, and
612,
hand
and
motion.
what is the expected visual acuity at the end of 1 year on the basis of protocol T? Sir, can you see the chat box?
One second. Yeah, so 3 is the correct answer. And we have Dr. Akshika.
So Akshika has,
With
yes,
the
yes.
fastest finger.
Akshika, congratulations on this answer, and you are right.
Thank you, sir.
So you had 2 questions or 3 questions?
Yeah. No, I had only 2 questions.
Thank you, sir. This has been a wonderful class, despite the internet disruptions, but it was a very well explained and a very comprehensive and crisp presentation. Thank you all the residents, ROS executive, teachers, and Dr. Raja sir for the excellent teaching. We look forward for the next class in the coming week. Thank you, and keep giving your feedback and suggestions for the experience to improve. Do subscribe to the ROS official channel on YouTube. All previous classes are uploaded there. Good night from Team ROS. Thank you, sir. Thank you so much.
Bye, Vishal. Bye, Dr. Narayanan.
Thank you.
Bye.
Manisha and Akshika, your grand prizes will reach to your workplace very soon. Thank you, sir. Bye.
Bye.